The last time I had the opportunity to be here, I had the honor of being on a panel with Governor Inslee and former Maryland Governor Martin O'Malley, talking about the challenges of healthcare, particularly from a state perspective. And I think that one of the ways the states and the federal government differ on this issue is that states have to operate on a balanced budget, which means that the cost of healthcare competes with everything else in the general fund. So it's very urgent, it's very visible, it's very immediate. And Congress, on the other hand, has the luxury of pushing difficult political choices into the national debt, which reduces the political pressure to actually find a meaningful and long-term solution. So I think deficit financing at the federal level is one of the reasons that we're having trouble solving this problem. But I think there's a deeper and more fundamental reason, and that is the way the debate has been framed. And it's been framed in a way that almost guarantees that we can't solve the problem. And that's what I want to talk to you about this morning, the necessity of changing the way the healthcare debate is framed as a prerequisite for developing a comprehensive solution, and how we might change that frame, and finally, the role that states can play actually in making that happen. So let me start with an observation that some of you, it may have occurred to some of you, but healthcare is the only economic sector that produces goods and services that none of its customers can afford. And the only way this works economically is that the cost of healthcare for individuals is heavily subsidized, increasingly with public resources, either directly through Medicare and Medicaid and CHIP, or indirectly through the tax exclusion for the employer-sponsored coverage or the subsidies that are offered through the ACA exchange, right? 92% of Americans rely on public resources to help finance the cost of their health care. If you're on Medicaid, it is a state and federal subsidy. If you have an ACA exchange plan, it is a federal subsidy. Group coverage, your subsidy comes from the federal government and your employer, and Medicare, of course, is funded primarily with federal dollars. So I would submit that what is in contention in the healthcare debate is the allocation of public resources and who benefits from that allocation. People who can afford the cost of their care are not the problem. And public resources have two distinct characteristics. First, they're a kind of fiscal commons. They're raised from all of us and should be spent in a way that benefits all of us, not just some of us. So there's an equity component involved. And secondly, public resources are ultimately finite. They're limited, which means that public dollars spent on one set of services are not available to spend on another set of services. So the more we spend on healthcare, for example, the less we have to spend on infrastructure or education. The problem is that most of the proposals to address the challenges of our healthcare system from both the left and the right, and the Republican Party and the Democratic Party, fail to recognize the importance of equity in the allocation of public resources and the reality of fiscal limits. So to illustrate that, let's go back to our subsidy map. The fact is that the only people who don't get a public subsidy in this country are the 27 million uninsured Americans, the vast majority of whom are working. Now think about that for a minute. While not eligible for a public subsidy themselves through their taxes, they subsidize the health care for everybody else. That's one of the most egregious inequities in the healthcare system, and it's part of what's driving the debate. This is a matter of access, but it also reflects an inequity. And to address it, we have to expand access. The problem is efforts to expand access and achieve universal coverage generally ignore the reality of fiscal limits. So the way the debate has been set up as a political choice between cost and access is the source of a lot of the gridlock. And the reason it's been set up this way is that neither Republicans or Democrats assume any fundamental change in the underlying healthcare business model or cost structure. We either pay for it or we don't. That creates this zero-sum false choice between cost and access. So the Republican efforts to repeal and replace the Affordable Care Act in 2017 were efforts to reduce funding for the existing structure, right? And so they would have expanded the number of people without coverage and made the inequity worse. By the same token, Democratic efforts to achieve universal coverage dramatically increase funding of the current business model and run into the reality of fiscal limits. So unless we can change the way the debate is framed, there's no way to get beyond where we are today. We need to figure out how to reframe the debate. And I think there's a couple of things that are necessary. First of all, we have to ask the right questions. And second, we have to have a pretty good sense of where we want to end up, our policy objective. So I love this quote from Gravity's Rainbow: if they can get you asking the wrong questions, they don't have to worry about the answers. So for decades, we've been asking the wrong question. We've been focusing on the subsidies, how much they are, who pays them, who gets them, how they're delivered, rather than focusing on the real question, which is why healthcare costs so much in the first place, and why we're getting so poor population health statistics for this enormous expenditure of resources. I think as we know, there's a lot of reasons healthcare costs so much. Some of the things we can address, some of them we can't. We can't address the aging of the population. But I think one of the biggest drivers today that we can address is this growing focus on maximizing revenue across the system. Not only are unit prices for almost everything in the U.S. healthcare system higher than they are in all other OECD nations, but there's this significant uptick in private equity investors buying up the most profitable parts of the system. Not just any part of the system, the most profitable parts of the system. That has everything to do with the market and not very much to do with health. Now, I recognize the importance of a functional market, but we have to remember that a public dollar that comes from a finite pool that goes to increase the profits of a Wall Street investor or pad a hospital margin is a dollar that's not available to expand access or reduce premiums or invest in the social determinants of health. And in a system that increasingly depends on public resources for its very stability, that is a huge contradiction that we cannot continue to simply ignore. Now, in addition to asking the right questions, we have to have a good sense of where we want to end up. No wind is the right wind if you don't know what port you're sailing for. So what is our port? Where are we going? What's our destination? What are we trying to achieve? Is our goal just to finance and deliver medical care, or is it to actually improve health? I would argue that it's the latter. I think it's fair to say that none of us want to be patients. None of us want to need the U.S. healthcare system. We'd much rather be healthy. But obviously, when we are sick or injured, we need access to quality, affordable medical care. But at the end of the day, healthcare is a means to an end, not an end in itself. It has no intrinsic value outside its relationship to a positive health outcome or the alleviation of suffering, except as an economic commodity. And that is how we treat it today. Furthermore, among those things that have the greatest impact on lifetime health status, healthcare is a pretty minor contributor. Far more important are things like healthy pregnancies, nutrition, housing, stable families, safe communities, education, a good job, the social determinants of health. But more than anything else, as the cost of healthcare increases, it's undermining and constraining our ability to invest in the very things that improve our health as a society. So if we can agree that health is our objective, and if we can't agree on that, we're in big trouble. But let's assume that most of us agree that we're trying to produce health here, then we can capture our policy objective in one sentence: to improve the health of the population through a financially sustainable system that ensures all Americans have timely access to affordable, quality medical care and can make long-term sustainable investments in the social determinants of health. Now, to achieve that policy objective, there are 5 key design elements that are necessary. You have to have universal coverage for a defined benefit with the delivery system at risk for quality and outcomes, in a global budget that's indexed to a sustainable growth rate, with some of the savings invested upstream in the social determinants of health. It's important to remember that a system that incorporates those 5 elements can take a variety of different forms. But without all 5 elements, you can't actually achieve that policy objective. The greatest obstacle to achieving that policy objective is the total cost of care and cost shifting. Because as the total cost of care continues to increase and approaches the point where private employers and the government simply can't afford to pay it, instead of managing that cost and trying to contain that cost, they simply shift the cost through 5 different strategies: cutting eligibility, cutting benefits, increasing co-payments and deductibles that shift cost to individuals, cutting provider reimbursement rates, often to the point that providers refuse to see or try to avoid seeing people who can't pay or who can't pay commercial rates. So an example of that would be your public option, which essentially caps reimbursement at 160% of Medicare. Or, and this really troubles me, just pushing those costs into the national debt and shifting the burden of paying them to our children and grandchildren. I mean, are we proud of that? $23 trillion in national debt, and it's increasingly being driven by the cost of Medicaid and Medicare. Republican efforts, if you look at their proposals, generally are on the left side, cutting eligibility, benefits, and increased cost sharing. Democrats tend to focus on cutting in reimbursement and increasingly driving these costs into the national debt. So cost shifting is the way we avoid directly confronting both the reality of fiscal limits and the fact that healthcare in the United States has simply become unaffordable for individuals, for employers, and for the government. Cost shifting does not reduce the total cost of care. This is the single most critical structural system problem we have. If we cannot solve this problem, we can't really move forward. There's no ceiling on the total cost of care because the major third-party payers have off-ramps. They don't have to actually manage it, they can shift it. It's like whack-a-mole. And as I said, cost shifting doesn't reduce the total cost of care. So how do we move beyond this? If we go back to our 5 design elements, 3 of them include universal coverage for a financially sustainable system that allows us to also invest in the social determinants of health. The fact is, the only way you can have all 3 of those at the same time is that universal coverage has got to be accompanied by a reduction in the rate of medical inflation. It's just arithmetic. And it might offer the political sweet spot, that space in which we can deal with Republican concerns about cost and Democratic concerns about quality and access. And over the last 7 years, Oregon has demonstrated that it's also politically and clinically possible. And let me just give you the highlights. In 2011, Oregon, like every other state, was in the depths of the Great Recession. We had high unemployment, we had a huge budget deficit, and about half of that was in the Medicaid budget. And it was clear that we were faced with provider cuts of up to 40% and dropping tens of thousands of people from coverage, the old traditional cost-shifting strategies. We decided to come together and not go that way. We decided to try to redesign the Medicaid care model to get more value for each dollar spent. And that created something called coordinated care organizations. These are new organizations that are locally based, partnership with local providers, local citizens with a local governance structure, and they try to move beyond the narrow clinical model and look more broadly at community health. In March of 2012, with broad bipartisan support, we passed the legislation that created the CCOs, the Coordinated Care Organizations. And in May, I went to DC and convinced the Obama administration to give us the Section 1115 waivers to use this care model to deliver care in the Medicaid program, and also a $1.9 billion one-time 5-year investment in exchange for a commitment to reduce the Medicaid cost trend by 2 percentage points by the second year of the waiver, from 5.4 to 3.4% per member per year, with no reduction in enrollment or benefits, and while meeting rigorous metrics about quality, outcomes, and patient satisfaction. And this, excuse me, this, you know, it's interesting that we all take a drink of water when we talk like this, and actually we're not pouring it down the trachea, which is where it really needs to go, but somehow we think it helps. And apparently I don't believe it anymore. The 5-year investment is really important because you can't change the system overnight. What it did is it gave us a 5-year glide path. And that investment gradually went down as the cost savings from the CCOs gradually went up. And that's essentially what happened. During the first 5-year waiver period, the state operated within the 3.4% growth cap. We added another 385,000 people under the ACA expansion. All the CCOs met their quality and outcome metrics, and we realized a total fund cumulative savings of over $1 billion, which is expected to grow to $8 billion over the course of a decade. Now, there's some lessons that we've learned from this. First and foremost, we know that it is possible politically and clinically to expand access and reduce the cost of medical inflation. But we've learned some other things. We've learned that to sustain universal coverage over time, all parts of the system have got to be under this growth cap. Medicare, Medicaid, the commercial market, prescription drugs, medical devices, and everything else. So for example, in Oregon, since we haven't yet been able to expand this care model to the commercial market, I wouldn't be surprised that if over time that 3.4% constraint in the Medicaid budget is reflected in increased rates in the commercial market. In other words, a cost shift. And since we currently don't have prescription drugs under the cap, it means for a given CCO, if they have one or two individuals that need a drug that costs $500,000 a year, you can put the whole global budget at risk. Now, you may face the same challenges with your public option here in Seattle, and I commend you for passing it. And at the same time, like Oregon, it doesn't seek to control total costs over the whole system, but just a sliver of the system, in this case, the individual market. And so it doesn't appear to me, and maybe I'm wrong, that there's anything to keep providers from compensating for that lower reimbursement in the individual market by raising rates in the commercial market. So how do we weave together these lessons and the 5 design elements that we talked about earlier into a strategy that can begin to move us forward? Well, after over 40 years immersed in the practice and policy and politics of healthcare, I've become convinced that the path to a more equitable and sustainable system runs through that part of the system that's financed with public resources and involves a market approach that consolidates public sector purchasing power. Now, I know most providers don't believe that public reimbursement covers their costs. And that's certainly true if you assume that you don't have to make any change in your business model or cost structure. But I would suggest that that's a very perilous assumption, given the changes that are taking place around us, which include more aggressive efforts by large self-insured employers to shield themselves from the cost shift, and this relentless increase in public sector reimbursement as a part of the payer mix as a result of the aging population. So my point is, constraints on public spending are coming. They are inevitable. So the smart play is to build that reality into our long-term strategy rather than simply pretending that it doesn't exist. So what might that look like? Let me preface this by saying I'm going to offer one way to skin this cat, a system with the objective of improving health that incorporates those 5 key design elements, right? And I think ultimately you can write this in a number of different ways, which will ultimately be dictated by the interaction of the stakeholder politics, but within the frame of a policy of improving health and these design principles. So instead of blowing up the current system, we would start with our current public-private financing structure and then modify the 3 large insurance pools that currently define the U.S. healthcare system. So pool 1 would be Medicare and the uninsured, and we would create incentives to move that system into a CCO-like model and use those savings to help finance the expansion. People with incomes under 400% of the federal poverty level without group coverage would have the option to participate. We'd have income-based subsidies and cost sharing above 200% of the federal poverty level. Pool 2 would be Medicare. We'd create incentives to make it easier and more attractive to enroll in a Medicare Advantage plan and then try to move Medicare Advantage from fee-for-service to some kind of capitated, delegated model, perhaps like the one that is being piloted in California by America's physician groups. For these 2 pools, we also have to create incentives to ensure that health plans don't simply use denial to manage cost, but shift the risk downstream to the providers where that risk can actually be managed. And then pool 3 would be the existing employer-sponsored medium group, large group, and self-insured market that would continue to operate pretty much like it does today with prices negotiated between the employers and the health plans and the providers. Now, this proposal involves consolidating the purchasing power in pools 1 and 2 to negotiate prices. So I would argue you would have one price for pool 1 and 2 because it doesn't make any sense to provide 2 different prices to treat the same condition. And I would argue we would move Medicaid rates to Medicare rates, and you could probably push Medicare rates even a little higher towards commercial because it is neither politically possible or economically, I think, desirable to suddenly take a whole lot of money out of the system precipitously. What we're trying to do is cap the total cost of care at some level and then link the growth of that to a sustainable level, right? To create a delta of savings over time that can help fund expansion and invest in the social determinants of health. So what essentially I'm suggesting is that the government do what every large private sector employer does, use their purchasing power. In this case, we would be using the purchasing power of pool 1 and pool 2 to get the best prices and the best value for our constituents, which in this case are the taxpayers of the United States. And we can't just limit this to hospital and physician prices or rates. We have to repeal that provision in Medicare Part D that prohibits negotiating drug prices. We would include drugs, medical devices, physical therapy, imaging, lab, ambulatory surgery centers, and all these multiple niche markets that have developed over time, focused on maximizing revenue, increasingly financed with limited public resources. This system then would achieve universal coverage built on our existing public-private financing system. A majority of Americans would be in some form of capitated care model. We'd reduce the total cost of care by negotiating prices in a global budget that's indexed to a sustainable rate of growth. Providers would assume risk and accountability for quality and outcomes within that budget. It preserves consumer choice. Current insurers can compete for those in pools 1 and 2, which is essentially a modified market, and it creates room in the budget to invest in the social determinants of health. A bold idea? Absolutely. But we're not going to solve this problem by pussyfooting around the edges. It's going to require courage, it's going to require boldness, it's going to require collaboration, and it's going to require taking some risk. For the last 2 years, I've been involved in an effort to try to reframe the national debate around a shared policy objective and some agreed-upon design elements in DC with mixed results. DJ put an article out in, I think it was late summer, describing my efforts, and the article's called Don Quixote Goes to Washington. I'm going to continue working on that during this election cycle anyway, and I would invite you to join me. But I also recognize that given the deep partisan nature of our nation's capital and the entrenched stakeholders, that the likelihood of Congress doing anything remotely like this in the near term is very, very marginal. But I don't think we can wait. I don't think our people can wait. I don't think our businesses can wait. I don't think our country can wait. So let me offer you a thought. Supposing we were to explore the idea of, in addition to our efforts to change the national healthcare debate, we tried to put together a 3-state collaborative, Oregon, Washington, and California, to try to advance this kind of reform. Now, there's precedent. Since 2008, these 3 states have been involved in something called the Pacific Coast Collaborative, which includes British Columbia. So it's an international governmental entity that tries to build consensus to solve regional problems. So, for example, in October of 2013, I joined Governor Inslee, Governor Jerry Brown, and then BC Premier Christy Clark in San Francisco, and we signed what is called the West Coast Action Plan for Climate and Energy. Again, a collaborative effort to try to address a regional problem. I'm suggesting that we explore the possibility of putting together a 3-state collaborative modeled after the Pacific Coast Collaborative to address a regional approach to healthcare. Now think about it a minute. These 3 states have all expanded under the ACA. Together, collectively, they are the 5th largest economy in the world, and a system along the West Coast would have a huge impact on the national healthcare debate. And even before we expand Pool 1, and even before all the baby boomers are eligible for Medicare, we start with a purchasing pool of 23 million people. Consensus, as DJ pointed out, in our nation's capital is becoming almost impossible. Almost impossible. But consensus has and will continue to be possible along the West Coast. We see it every day. And that consensus would be backed by 3 governors and 6 U.S. senators and 68 members of Congress. And to the extent that we would need federal flexibility and federal waivers, we have 2 members, Senator Wyden and Senator Cantwell, on the Senate Finance Committee, and the West Coast delegation has 10 members on the House Committee on Energy and Commerce, the 2 relevant committees on healthcare in the United States Congress. You know, DJ started this out talking about, can the center hold? Can our institutions actually deliver for us? And I do think the filibuster that he mentioned in many other ways, the United States Congress has become dysfunctional. The center is at risk of imploding. But that stain of partisanship, that stain of incivility, has not yet reached the West Coast. Partisanship's a choice. Civility is a choice. Collaboration is a choice. You know, I was born here. I was born in the Pacific Northwest. I've been a West Coast governor. And I have this deep and abiding belief in the people of this region and their ability to do what's right, their ability to pull together in common cause. And so let me just leave you with one of my very favorite quotes from The Sound of Mountain Water by the great Wallace Stegner. One cannot be pessimistic about the West. This is the native home of hope. When it fully learns that cooperation, not rugged individualism, is the characteristic that most characterizes and preserves it, then it will have achieved itself and outlived its origins. And then it has the chance to create a society to match its scenery. And I would add, a healthcare system. Thank you.
Great stuff. Boy. So when you talk about these pools, pool 1, 2, and 3, do you see those being multi-state pools? Would we have a multi-state regulatory apparatus that would need to be aligned so that somebody could buy a plan that's similar in California and in Washington?
I think the most important aspect of this is to kind of consolidate the purchasing power in terms of developing. So let's use Medicare Advantage as an example. So Medicare Advantage essentially is a system where the plans are provided with a fixed amount of money for the contract period and a set of outcomes. There's regional differences in terms of what that global budget looks like. So I think to me this has got to be a sort of a federally designed, in terms of the benefit package and the negotiation of prices, but then I think that global budget goes to the state and regional level, not unlike the CCOs, where there are entities certified that can actually then bid for that. So in Oregon, we've got 15 CCOs. They're all different in different parts of the state. They operate differently, but they're all required to operate under essentially the same global budget and produce the same outcomes and quality and the same kind of engagement with the local community. Mm-hmm. And I don't think you can just do this nationally. I actually really do think you almost have to start regionally. And it has to be a big enough market to make a difference, which is why the West Coast, I think, lends itself to this kind of effort.
So one of the things that I've learned as we've hosted this event in Oregon over the years, a lot of people there compare or they look to public education as a model for this conversation, meaning there's broad access to public education, it's affordable, i.e. tax dollars, free otherwise, and there's this defined benefit that everybody is going to get the same K-12 or access to the same K-12 education, and we are not going to educate all people in all things, we're going to educate them in these things. Is that what you're getting at? Is that a model when you talk about defined benefit?
I think that's a good model. Just think about it a minute. So we pay for public education with public dollars because it's a public good. We all recognize the importance of education on a whole lot of levels. So everyone helps pay for public education. Rich people, poor people, people who don't have kids in school, right? We all pay for it. And all our kids are eligible for the public education. They get the same benefit, which is a 12-year education. You can argue about the quality of that, but they get the same benefit. And what happens when we run out of money? We don't say we're going to stop education at the 10th grade, or people who make more than $40,000 can't go to school. Universal coverage. What we focus on is the benefit, right? And it goes up and down based on, and if you want extra benefits, if you want to give your kid a tutor or take them to a private school, you can do that, but you do it with your own after-tax dollars, right? So I think that's what we're talking about. There has to be some basic, in my view, portable benefit that is good and like the Oregon Health Plan benefit, it's a very good benefit. And then people can buy additional benefits on top of that. So if you're Intel or a timber company, you may want a different benefit design to attract the kind of workers that you want. But we don't argue about the basic benefit, and that is something that's funded with general tax resources, which is where we're heading right now. We're increasing the public financing of medical, but there's no system into which those public dollars flow. Very fragmented.
So part of that defined benefit conversation or the thinking comes out of the prioritized lists that you all implemented back in 1990 or thereabouts?
89.
89. Tell us about what you've learned. Tell us about what that is. Tell us about what the state of Oregon has learned from that process and how that might inform where the level on the benefits is placed.
So in 1989, we were doing what every other state was doing. When we ran into a shortfall in the Medicaid budget, we'd simply change income eligibility to basically redefine the poor. And I was co-chair of what's called the E-Board in 1985. We used to have a biennial legislature. In between terms, there was an emergency board that managed fiscal matters, chaired by the Senate President and the Speaker of the House. And we had a $40 million hole in the Medicaid budget, and so we came in and we put a little money in and nicked provider reimbursements a bit and changed eligibility and dropped 4,300 people from coverage. And I was sitting there thinking, well, that was easy. Look at a piece of paper, take some votes, budget's balanced. And then I went back to the ER in Roseburg, and in September, I saw some people starting to come through the door that had lost coverage because of that decision in May. And one of them was a middle-aged man who suffered a massive stroke because he no longer had access to his blood pressure medication. And it just hit me like a load of bricks. And I was as responsible for his death as his hypertension, because I would participated in actually excluding him from coverage. So what we said is, look, we're going to cover everybody below 100% of the federal poverty level, including the non-categorical folks who weren't categorically eligible under Medicaid. So what we did in '89 was what the ACA did in 20 years later, right? Our floor was at 100%. So we basically developed a process to prioritize health services based on clinical effectiveness and the health benefit for the entire population. And that was given to an independent actuary that determined the cost of providing each element. And that list and the cost was given to the legislature. So the legislature could no longer arbitrarily cut provider reimbursement rate. That had been predetermined with input from providers. And they could no longer change eligibility because we'd set the eligibility in statute. So all they could do is everyone stayed covered, and we took benefits off the bottom that were less important. So you can imagine, I was called Dr. Death in the San Francisco Chronicle, and it was kind of a rough time. But as it turned out, we increased Medicaid eligibility more towards Medicaid, and we had dozens of different provider groups that signed up to provide care. It's a rich benefit package. It does really good by pregnant women and children because of the place those services offer on the priority list. And we've been using it for 30 years.
And it's based on efficacy,
it's
right?
Based on clinical effectiveness and social values. There's a community engagement process. What it didn't do, and I'll be the first to admit, is it didn't actually question the underlying cost structure of the delivery system, right? It was really an issue of equity in the allocation of public resources, right? Everyone was going to get the same thing. So that's what the CCOs were. We in 2011, when we had the revenue shortfall, it became clear that the real problem, you need the equity, you need to allocate public resources equitably, but you got to actually look at the delivery system. And so the CCO model was an effort to change the delivery system, and we still use that prioritized list in the CCO model.
So that prioritized list is edited and updated every year?
Every 2 years, you can go online. It's pretty fascinating.
And now Oregon's talking about things like putting housing and social determinants on that list that turn out to be sometimes more efficacious than surgery.
We're looking at how you would integrate social determinants. Now that's not to say that we are going to medicalize social determinants, but if you're in a budget process with limited resources, this is a ridiculous example, but what's the population health benefit of non-surgical treatment of low back pain versus housing or childcare or healthy pregnancies, right? I mean, it creates a forum where we can have those conversations, and it's not always easy, but it's pretty fascinating.
Well, I got to tell you, I was an admirer of yours before I knew you. I've gotten to become an even greater admirer of yours. I appreciate your leadership, which is courageous and thoughtful and willing to look at the evidence and use logic. I just think we really are indebted to you for your leadership. Let's give Governor Kitzhaber a round of applause. Thanks, sir.